Marty Goldman. Welcome, everyone. We're actually starting today the new academic year in our Controversies in Cardiology series, so welcome, everyone. It's a very, very good panel that we have for this year of speakers. I'll get to that in a moment. I want to wish everyone happy, healthy New Year. Let me just tell you a little bit about people who we're going to have this year. September, we have Alan Klein, who we'll hear later today. In October, Chris Granger from Duke. In November, Dr. Joseph Rhodes Cabot from Quebec. In January, Keith Aronson, University of Michigan. In February, Dr. Tusku from Cleveland Clinic. In March, Dr. Yancey from Northwestern. In April, Dr. Fanaro from UCLA. In May, Dr. Rader from University of Pennsylvania. And in June, we have Dr. Leon from across town at Columbia. The format for our program is the fellow. Today will be Inez Sharif, who will give us an overview of the topic. And we have hopefully a very dynamic panel discussion led by Dr. Fuster. So because he introduces our visiting professor, and we rarely introduce him, let me just give you a little bit of background. Dr. Fuster. He is Physician-in-Chief Director of Mount Sinai Heart, the Zena Michael Wiener Cardiovascular Institute, the Maria and Josie and Henry Kravis Center for Cardiovascular Health, and the Safra Institute for Cardiovascular Research, the Richard Gorlin, MD, Heart Research Foundation Professor. He was the past president of the American Heart Association and the World Heart Federation. He is editor of two major textbooks in cardiology, and including The Heart, previously edited by Dr. Hurst, and he's the current editor of the Journal of American College of Cardiology. He's the only cardiologist in the world to have received the two highest gold medal awards and all four major research awards from the four major cardiovascular organizations. And he's also my number one person to go to for education of us all. Without further ado, I'm just going to ask Dr. Fuster, who's going to introduce, Inez, do you want to?
Changing format. I think that's fine. Sure. Okay, thank you very much, Martin, for your long presentation that I don't deserve, but I really appreciate your words. Now, it's a pleasure today to introduce Dr. Alan Klein, who is Director of Pericardial Disease Center, Cleveland Clinic, and Professor of Medicine at the Lerner College of Medicine of Case Western University. Well, we'll make a long story short, but I will say a few words about a very accomplished individual, particularly in the area of imaging. Now, Dr. Klein obtained his MD degree at McGill University in Montreal, internship at Mount Sinai Hospital in Toronto, residency in medicine at the Royal Victoria Hospital in Montreal, then became a fellow of cardiology at the University of Ottawa in Ontario, and then he moved to Mayo Clinic, where he was a research fellow between 1986 and 1988, working with Dr. Emil Tajik and Dr. Seward. Now, he became a real expert after being at Mayo Clinic on three modalities of imaging, which is unusual, which is echocardiography, cardiac MRI, and computer tomography. Now, as I mentioned, he's now the director of the Center for Diagnosis and Treatment of Pericardial Diseases and professor of medicine. Now, the question I will ask him later is whether he believes in multimodality imaging as the training. I mean, more than two imaging technologies that somebody becomes an expert of. I think you are the only one I know thus far. Having said that, Dr. Klein has been appointed president-elect of the American Society of Echocardiography in the upcoming year. He's in the writing committee of the National Board of Echocardiography, and he is He's an editorial board and peer reviewer of more than 15 professional journals. He has been the principal investigator of a number of studies, trials on atrial fibrillation, and trials on diastolic dysfunction, catheter ablation, valvular heart disease, etc., always with his expertise in the field of imaging. Now, he has been the director of the annual Diastology and Valve Summit courses for the last 17 years. And I think what is most interesting is his bibliography. He has been a very innovative mind in the area of echocardiography and imaging. He has more than 250 papers in the literature with a very high peer review system. So it is a pleasure to introduce you here, Alan, and to be part of our visiting professorship. This is how the plaque reads, is the faculty and fellows, and I go on and on and on. Express appreciation to Alan Klein for outstanding teaching, wisdom, and expertise as the Anandi Sharma Visiting Professor and the Simon Duck MD Memorial Lecturer, September 21st, 2015. Congratulations. Okay. Good. Thank you. You will put this inside. Thank you. There's another envelope, which is the check. Okay, so Inez is okay. You know, I know. She has done a fantastic job, by the way. This is a wonderful review of a subject that I must tell you the following. This is the most difficult subject I had to really try to put together in the last 3-5 years. This normal ejection fraction, restricted disease, I can tell you, this is tough.
Thank you. And with that introduction, I can talk to you today about today's topic of controversy, and it's heart failure with preserved ejection fraction. But before I do that, I just wanted to say welcome to Dr. Klein on behalf of the fellows. It's been a great day to spend time with you, and I think a lot of the fellows also appreciate your book that we used to study for the echo boards. So thank you for that as well. So my hope today is that during the discussion we can touch upon the controversies surrounding the nomenclature, diagnosis, and management of this condition. And I'm pleased today to essentially have a short 5 to 10 minute speech that I thought I could do by providing some answers to my own questions. If you bear with me, I have 3 questions. Question number 1, why should we discuss this topic today? Question number 2, why is the nomenclature of this condition confusing? And question number 3 is really, how can we treat it? So the first one is, why should we discuss this topic today? Heart failure with preserved ejection fraction currently represents half of all heart failure presentations and is actually projected to become the most common form of heart failure in the future. Despite that, there is actually less awareness of this condition than there is about heart failure with a reduced ejection fraction. In terms of the heart disease and stroke statistics, data shows that about 5 million people suffer from heart failure in the United States, and about half the people who develop heart failure actually die within 5 years of the diagnosis. Compared to patients with a reduced ejection fraction, patients with a preserved ejection fraction are generally older, more likely to be female, have a higher prevalence of hypertension, chronic obstructive pulmonary disease, and atrial fibrillation. Conversely, these patients actually have lower rates of the traditional cardiac risk factors that we think about. So these are smoking, diabetes, hyperlipidemia, peripheral vascular disease, angina, pre-RMI, and prior coronary artery bypass surgery. Although initially thought that mortality in this condition, in heart failure with preserved ejection fraction, was actually lower than mortality in heart failure with reduced ejection fraction, recent studies have shown that hospitalized patients with heart failure have a high 30-day and 1-year mortality, similar to patients with a reduced ejection fraction. It is important actually to also realize that these patients suffer lower rates of cardiovascular deaths and higher rates actually of non-cardiovascular deaths. And that's something important that we will touch upon. The second question is, what is the correct nomenclature for this condition and what does this mean? The condition itself actually was first described in 1937, and this was by Dr. Fishberg, who coined the term hypodiastolic and hyposystolic. And actually about 17 years ago, Dr. Klein coined the term diastology as part of his work. So it's a great honor to have him here today and discussing this topic. However, despite the work that has occurred over the past decades, this condition has actually long puzzled the medical community. Interest started to increase in 2001 when 38 patients were admitted with heart failure and they were found to have ejection fractions greater than 50%. Perhaps the reason that there's so much controversy over the nomenclature of this condition is based on the fact that the wording has changed and our understanding of this condition has evolved. All of this has actually happened in the last 2 decades, and as this, we have a better understanding of the evolving wording. Many people have called this diastolic heart failure. However, what we will see is that this suggests a clear distinction between systole and diastole, which is often difficult to measure physiologically, and it also assumes a normal preserved ejection fraction. Others have said, let's call this small heart failure versus large heart failure, and really this does not do justice to the complexity of this disease. Several other groups have called this heart failure with a normal ejection fraction, and actually this does not include those patients that have mild impairments in ejection fraction. Perhaps the most current terminology refers to the disorder with heart failure with preserved ejection fraction in an attempt for us as cardiologists to measure a highly subjective disease and complex condition, but still include some mild impairments in ejection fraction. And the last question, actually, is what causes this clinical entity and how can we treat it? None of the current trials and heart failure treatments have shown a mortality benefit or improved survival for patients with heart failure with preserved ejection fraction. I hope that we will see some of the trials during the discussion today, but really this includes beta blockers, calcium channel blockers, ACE inhibitors, ARBs, and spironolactone. Some promising data and some small studies with sildenafil with the reduction in pulmonary pressures and LV relaxation and distensibility. Much work has been undertaken with Doppler echo, strain imaging, biomarkers, and microRNAs so that we can better diagnose this condition. The fruits of this translational work have markedly increased our understanding of the cellular and signaling pathways in heart failure with preserved ejection fraction, in the fact that it's actually a distinct entity from heart failure with a reduced ejection fraction. And the changes are seen at the microscopic and histological level. And they're actually a direct result of a pro-inflammatory metabolic milieu in a susceptible patient with obesity, hypertension, diabetes, COPD, anemia, and CKD. A molecular signaling cascade resulting in increased endothelial inflammation at the cellular level causes LV diastolic dysfunction. The treatment of these concomitant and comorbid conditions as part of a global approach to patient care becomes very important. This is especially crucial in a disease paradigm where the presence of diastolic LV dysfunction is only the tip of the iceberg in a pro-inflammatory systemic heart failure with preserved ejection fraction syndrome. Thank you. And thank you, Dr. Goldman.
Thank you very much for putting together a very difficult subject. And we are now going to call to the panelists as Dr. Anu Lala, Marianne McLaughlin, Hussein Penny, and Partha Gupta, and of course, your Ines. Well, you had 3 questions to answer. I have 20. And the question is, how can we do this within an hour? That's what is needed. And the only thing I'm going to ask the panelists is to really answers that do not last more than 30 seconds to 1 minute. Otherwise, it's going to be very difficult to get into a complex subject like this with many ramifications. I will just say from the beginning that I divided this subject in 5 different groups. The first 4 aspects will be about introduction, the first 2 about heart failure in general, and the other 2 will be about heart failure with preserved ejection fraction in particular. The second will be the issue of how strict we have to be in defining this entity. I think it has been out of the, everything appears to be having heart failure with left ventricular dysfunction, and we are not strict. If we are not strict, we are absolutely in the wrong track. The third will be about the accurate way to make the diagnosis. And then the following will be the pathophysiology, which to me is the most important part to understand what we are talking about, and then the different modalities of treatment. So let me begin by starting with a couple of aspects of introduction that really relate to cardiac failure in general. And I think it's worthwhile because you mentioned this in your presentation, certainly. The first one is that in our society ages, and there is a 20% lifetime risk for an American over age of 40 to develop heart failure during their life. And heart failure constitutes the most common cause of hospitalization in patients over the age of 65. So this is the reality that we cannot escape from. The second reality, which perhaps maybe some questions about it, is about half of the people who develop heart failure die within 5 years of the diagnosis. The key question, as we will discuss today, is whether the diagnosis is right or wrong. And the third issue is about the cost, which today is fashionable always to say how much one spends with disease. It's $32 billion each year in this country we are spending with this kind of an entity. I'm talking about cardiac failure in general. Alan, do you have any comments about these 3 statements?
I can say that I've been in this field for over 20 years, more from the clinical aspect, how to diagnose the disease. And as you pointed out, Dr. Brewster, the terminology, nobody could agree on. Is this diastolic heart failure? I have a book called Diastology, focusing on diastolic heart failure. But is it heart failure with a normal ejection fraction or heart failure with preserved ejection fraction? And this aspect is being very important and also very important in the trials, because if you direct the treatment, whatever the treatment is, at the wrong group with a lot of comorbid conditions, you're going to get soup and basically no major effect, no mortality benefits. So I think the terminology, the definitions have to be exact. Whether an international summit should be convened and everybody sits in a room, the Europeans, North Americans, and everybody decides that this is who we should enter. So I think it's a very important area, as you pointed out. It's a disease of the elderly, and we have to define it a little more properly.
Thank you. The next 3 statements, after we discuss a little bit the incidence demographics, is about the comorbidities. And I like just to write these statements because I think are quite important. Recent data from the Centers for Medicare and Medicaid Services demonstrate that 55% of Medicare patients coded as having heart failure have at least 5 chronic comorbidities. This is absolutely critical, which makes the field of cardiac failure quite complex in general. And the second statement is more than 1/4 of heart failure patients have comorbidity, pulmonary or renal dysfunction, both of which are associated with an increased morbidity and mortality. And there are other aspects. We'll discuss anemia, sleep apnea, we'll discuss hypertension, and so forth. And the final statement is that the European Society of Cardiology pilot survey indicates that the majority of patients with chronic heart failure, 74%, had at least 1, 2, 3, or 4 comorbidities. So all is in the same way. So Inez, we discussed this by phone last night, and that is whatever we talk about heart failure, if we don't talk about what is around, in particular in the entity we are going to be discussing today, we are really completely offline. What do you think?
Yeah, absolutely, Dr. Fuster, especially in this clinical entity of heart failure with preserved ejection fraction, where a large number of people have such high comorbidities. And actually, a lot of the studies have also shown that the prevalence of these conditions in this patient population compared to patients with reduced ejection fraction is actually higher. And these would include, as you mentioned, COPD, sleep apnea, very often anemia as well. And, you know, in terms of, you know, these patients having heart failure with preserved ejection fraction, certainly that increases their mortality, increases their risk of complications, but definitely the comorbidities as well. These patients do have a very high mortality, but a lot of it is actually based on the comorbidities that they have and sort of the management of these comorbidities in this patient population.
I know this reminds me to atrial fibrillation. Atrial fibrillation, if you talk to somebody superficial, we'll talk about ablation, no ablation, yes ablation, no ablation. What is behind it? Is obesity behind it? Is hypertension behind it? And that is the lone atrial fibrillation that today probably is like the virus-related cardiomyopathy, is not the same. We are beginning to talk now about restrictive heart failure in which there is no ejection fraction is close to normal. You don't see it like a final manifestation of something else?
I think that's a really important point. We're constantly quoting data from Framingham that shows us that the incidence of atrial fibrillation increases as the New York Heart Association class worsens. So as we get up to New York Heart Association class 4, we see a higher and higher, over a quarter of the population with atrial fibrillation. And I think we tend to think of that more as heart failure with reduced ejection fraction, but the same is true as heart failure with preserved ejection fraction. And I think we constantly get at trying to understand markers of fibrosis that may be implicated as a part of that pathophysiology, and I don't think it's perfectly understood. I think it has so much to do with the comorbidities, as you already mentioned, namely pulmonary disease, hypertension, coronary disease as well. And I think this all adds to the complexity of really understanding this clinical syndrome and how heterogeneous it is.
Okay, thank you. Let's continue to move in a general way, and maybe Dr. Sengupta, I'd like you to comment on the following statement. And that's, now we are talking about the demographics of heart failure with still normal or near normal left ventricular ejection fraction. First of all, we are told that 50% of the patients who present with heart failure are actually this kind of an entity. I have a hard time to believe this for a long time. I still have a hard time to believe it today, but this will be part of the discussion. What I really like to ask is the following, and these are the statements. Hospitalized patients with heart failure and preserved ejection fraction tend to be 4 to 8 years older than those with reduced ejection fraction and are more often female. Now, the question is the issue of why females are more, I'm sorry for this, let me, it's my wife, this is the problem. And I say, I will hear tonight. I cannot say this is more important. Anyway, now the issue, because they are more often in female, is because we are not talking about, I suspect, coronary artery disease or some of these intrinsic diseases of the heart that affect more males. Is not correct? I don't know what I'm doing. Yeah. I'm sorry to go to this, but I will give her an explanation. And this is not closing. I probably need a fellow to come in. Let me just close it. So tell me why you think are females more common and then is more in the elderly population. What do you think?
So I think first of all, I think we are very simplistic in approaching as heart failure with preserved ejection fraction as a single entity. I think it's a very heterogeneous. It's almost like calling that cancer is a single disease. I mean, it's like you have multiple types of cancers. We now know that there are multiple phenotypic patterns, genotypic patterns. So same way, I think we have to approach heart failure with preserved ejection fraction as a syndrome which is highly heterogeneous and has multiple clustering of different risk factors, which we don't have much handle on. We know that it does present at an elderly age, but that's probably related to clustering of more risk factors with aging. And why it happens in females is potentially related to the specific pattern of ventricular remodeling that happens, where you get initial concentric remodeling rather than a dilatation of the left ventricle. And what are the cause and effects, and whether hormonal or genetic makeup correlate with that? I don't think we know much about it as yet. But just to say that it's a very simplistic to feel like heart failure with preserved ejection fraction, a single entity. I think it's extremely heterogeneous, and a lot of work I think needs to be done. Just like we do the phenotypic mapping in cancer, we need to probably go into a phenomapping approach and clustering of different types of presentation in heart failure with preserved
Okay, thank you very much. Dr. Pini, why African Americans who have much more hypertension than the rest of the population do not have more of this disease than the non-African Americans? This is a puzzle. What, do you have the answer?
Well, I wish I had the answer, but it's a great observation. I think, one of the things that we're talking about is hypertension, and that hypertension can express itself in many different ways in terms of end organ dysfunction, whether it's, the development of atrial fibrillation, heart failure, preserved ejection fraction. If you look at African Americans who become hypertensive, they're much more likely to exhibit non-ischemic cardiomyopathy, whereas in Caucasians you're much more likely to experience coronary artery disease and coronary heart disease. So why hypertension expresses itself in different ways, whether you're a man or a woman or African American or Caucasian, I can't really explain. But I mean, the other possibility is that it relates to nitric oxide. There's certainly the understanding that African Americans have much different NOS signaling than Caucasians, and that might also contribute to the different protein manifestations of hypertension in these two populations.
Okay, let's now move into something I mentioned before, Alan, which is how strict we are in the definition. And I'd just like to compare the definition of such entity, heart failure, with preserved ejection fraction from the American College of Cardiology, American Heart Association guidelines, and how these compare with the definition from the European Society of Cardiology. Just a moment, let me define both definitions. Now, the American Heart Association, American College says you need three things to make the diagnosis. First, clinical signs or symptoms of heart failure, fine. The second is evidence of preserved or normal left ventricular ejection fraction. There is a problem there. They can consider almost normal, even ejection fractions, as it is in a number of trials that follow the American Heart Association, American College, of ejection fractions of 41%. This is important to notice. And then the third issue is evidence of abnormal left ventricular diastolic function. Okay, we have these three definitions. Ejection fraction is rather loose, but here comes the European Society of Cardiology. Among these definitions, they are in favor to the number one, clinical signs or symptoms of heart failure. Their definition of preserved ejection fraction is absolutely more than 50%. So here is already an issue compared with the American definition. And then they define also left ventricular end diastolic volume index of less than 97 mLs per square meter. That is, the ventricle is small. So this is much more specific, but there is more in the European Society of Cardiology. And you need to have left ventricular hypertrophy or left atrial enlargement, or the relaxation measurements with Doppler should be abnormal. So here is an issue. If you take both types of definitions, 34 to 35% of the trials should eliminate patients with a restricted ejection fraction because they do not fulfill the definition from the European Society, which is quite strict. I think this is quite important because everybody talks about restrictive disease, but the question is, what are you talking about? And I'd like you to at least comment on.
So that's been one of the problems of definitions. Even before the European and the ACCHA, there was the NIH classification, a Leahy classification, and people have used EF of 40 to 50%, 45%. So the European is much more strict. It incorporates preserved EF more than 50%, a lower end diastolic volume index, and then you can either have some abnormality of distensibility, stiffness, either by cath, either by wedge pressure, EDP, or time constant relaxation. Then it throws in the tissue Doppler, EUV prime, and biomarkers. So it's very, very strict definition. It's hard to follow, but much stricter than the ACCHA guidelines. There they say they don't have the exact definition of diastolic stiffness. They say by echo or by cath. And this is a big problem in who gets into the trials because you are incorporating people EF of 40, 45%. What happens when the EF was, let's say, 39% and you give them medicines and now they're 50%? So these people could be incorporated. So as Partho mentioned, you have a hodgepodge of different EFs, and whether EF is even a good measure of a normal systolic function. And then you throw in all these comorbid conditions, which are not controlled for, and this is one of the problems. I think, as I mentioned, there should be a strict summit of heart failure, perhaps imaging people, and everybody sits in a room and decides what to include. And as you pointed out, 33% are not getting into some of these trials. So,
yeah, I think it's an important aspect because when we say it's the same incidence of one versus the other, we are very loose in defining restrictive disease with normal ejection fraction. But I want to go to Inés again. When you go to the literature of this disease, you read constantly the mortality is exactly the same when you have normal or near normal ejection fraction that if you have heart failure with reduced ejection fraction. And when you go into all the trials as I did, this is absolutely wrong. And in fact, there are statements done by the society that recently met about this issue that if the BNP, you put together BNPs being the same in both entities, then you drop significant number of people who do not have restrictive disease, then the mortality is the same, high BNP in both groups. I'm just like you to comment on, because I think this is also an issue that to me is wrong, and that is to say the mortality is the same, 50% in the 5 years of follow-up. I'd like you to comment on.
So by taking a look at these studies, there was one thing that was very important to notice. And the first one was that epidemiologically in the community, actually the mortality was higher than in the randomized controlled trials. And one of the reasons for that was cited was that perhaps patients that are admitted into the randomized controlled trials might be healthier. They may have a medical team that follows them, certain medications. So they're generally a healthier group. So that was first. Second, it was important to notice actually sort of some of the mortality data and what they were tracking. In the two major studies actually that had been published in the New England Journal, they were looking at mortality, so 30-day mortality and 1-year mortality. And the mortality was actually not that statistically different between the two groups. But in the group with heart failure with preserved ejection fraction, there was a higher mortality from the non-cardiovascular causes, from the COPD, so essentially from all the comorbid conditions that these patients suffer from.
This is critical, cardiovascular mortality versus mortality in general. And that's where the big problem is. About 1/3, you will see this in a moment when we go into the trials, about 1/3 to 50% of the mortalities are not cardiac, are related to the comorbidities that are affecting the disease. And this is why I wanted to point out that exactly what you said. We have to be very careful how we define mortality here. Well, having said that, now I'm getting into something that people like it, and you particularly on, which is the whole issue of imaging in trying to make the diagnosis. And I like to go step by step to be sure that we all understand the pros and cons of this. First, let me define diastolic dysfunction. Can you imagine me defining diastolic dysfunction? Well, I'm sure you will give me a help. Well, first of all, we have Doppler echocardiography, and then we have the issue of relaxation with the strain imaging. But let's go into Doppler echocardiography. It is my understanding that basically what you do, you measure the flow velocity towards the distal part of the mitral valve versus the atrium or the mitral annulus. And then the distal part is much faster than the proximal part. And then you give figures, the so-called EE ratio in the early stage of diastole that should be greater than 15 to say this patient has diastolic dysfunction. I am right, or I mixed up the whole thing?
So Dr. Fuster is asking about how you measure with echo Doppler, and I guess I spent a lot of my career doing this, and actually I'm working on new ASC guidelines as we speak, and I showed that to the fellows as an example. So basically what we try to do is to measure whether they have diastolic filling abnormalities. You're not measuring pressures, you're measuring indirectly inferring pressures. So you're not actually, there's no catheter, you're indirectly measuring filling pressures. So what people do is they measure the ratio of the E to A ratio at the mitral inflow tips. You're putting a sample volume. And you're looking to see whether it's very high, let's say an EA ratio of more than 2, which infers, with a short deceleration time, infers restrictive physiology, a stiff ventricle, decreased compliance, increased stiffness of the ventricle. That's the one extreme. And the other extreme is measuring at the tips and getting a low EA ratio. And that's somebody with a S4 on a clinical examination in pure relaxation. That's sort of a lower or normal filling pressures. And in between, you have what you call a pseudo-normalization. The EA ratio is between 1 to 2, 1.5. And then you have other things like tissue Doppler, which is a marker of relaxation. And people have used the E, which is like flow. E prime is a measure of relaxation. If you do the ratio, a high E or E prime more than 15, in small studies, mainly from Mayo Clinic in Houston and Cleveland, suggest high filling pressure. We come up with 4 criteria to assess this a little bit clearer. One is the EOV prime, whether it's elevated, say more than 15. The left atrial volume index, a marker, it's the hemoglobin A1C, like diabetes, how large your left atrium is. So the larger left atrium, more than 34, would be enlarged. Is there pulmonary hypertension, what the RVSP is, so that the TR velocity, and pulmonary vein flow. So from this concoction, you can decide whether pressures are elevated, or normal, or pseudo-normal, and then grade what type of abnormal filling pressures. Is it grade 1, for normal or low, 2, a little bit elevated, and 3, restrictive. So that's what we use, and we're trying to come up with guidelines. If you throw in, like the Europeans, the BNP, you may have a little bit stronger. Cath is used less. You're not going to do necessarily cath unless you want to do a hemodynamic exercise cath. But echo would be, I would say, the main way that a lot of these trials, should include some of this data. What's the evidence for EOV prime inferring elevated filling pressures? It's not that strong. And can you use this in the ICUs? You probably can't use it. That's the way we use it.
What about if you forget about the echocardiographers and you send the patient to a stress test and pulmonary artery pressures go up? What about if the patient goes to the cath lab and you measure just left ventricular and diastolic pressure going up? Is not more reliable?
Well, you bring up the concept of 2 concepts. One is sort of a diastology stress test, which you can do in a day-to-day echo lab during the treadmill or supine bike. You can get your baseline RVSP and your EV prime, and you do the treadmill, and you slam them down, and you In recovery, you can measure the EV prime. If the EV prime goes, let's say, from normal 8 to 15, you know that there's cardiac dyspnea. In the cath lab, you can do a hemodynamic stress test with catheters, Supoint bike, and show similar things. Obviously, the non-invasive way may be easier to do. Measuring a high EDP in the cath lab or high mean LA pressure will be another way. The Europeans do include the cath part, but I still think that the hemodynamics have moved away, unfortunately, from the cath lab to more the echo lab. So I think but both can be used more reliably.
What about, at least I learned this in JAC, because there were a number of papers that came out this year about this so-called myocardial tissue tracking, in which you are looking at relaxation. Can you explain to us how you do it? I'm sure most of the people know, but maybe some, like I do not know well. Can you explain it?
Sure. So tissue tracking. So we're talking about speckle tracking of the left ventricle. More to look at the contraction, the elongation, and the contraction of the heart. Looking at each of the myocardial fibers, there's a speckle involved with the left ventricle, and you can apply automated algorithms, for example, that measure the change in the length of each segment. There's a analysis called global longitudinal strain. We'll give you like an ejection fraction, give you a measure. Minus 21% will be normal, and this may add to the assessment of usually systolic function, but you can also do strain rate, whether you can measure diastole as well. So this may have a little more added value, and one thing that it's not only in diastole, you'll have abnormalities of strain in people with HFpEF or diastolic heart failure.
Anyway, very simple. Let's go into anew the biomarkers in microRNAs. I can tell you at least what I learned about this subject. And again, there's so much coming into the literature that we have to review for the journal. The one is BNP. And BNP, interestingly, everybody talks about it, but in about 1/3 to half of these people do not have an abnormal BNP. So we are in trouble there if you use it as a diagnostic thing. Now, it's interesting, the BNP, because it is released probably as a defense mechanism with this tension leading to vasodilatation. And I was thinking the interesting new drug, neprilysin, which in fact the BNP is blocked by neprilysin. And what the drug is doing is trying to block neprilysin, giving the BNP the pleasure to vasodilate. And then you give valsartan as angiotensin inhibitor and produce more vasodilatation. Well, it turns out that BNP is very controversial because it's not very sensitive, but certainly if it is elevated, leads to a poor prognosis. This is number one. Number two, there are these others, TNF, interleukin-6, and certainly CRP. I'd just like to know if this really helps you.
Thank you for
all these biomarkers.
I think biomarkers are sexy because they're sort of a number that you get back, and people like to be able to hang their hat on that. And I think you pointed out some of the shortcomings, particularly of BNP, namely that it is affected by the comorbidities that we see very commonly in heart failure with preserved ejection fraction. So we know that it is altered by obesity and renal function and age, and so I don't think that we can really hang our hats on that alone. But I do think that there is some role for it to be integrated into a more comprehensive definition of heart failure with preserved ejection fraction, as you mentioned. There was also some interest in looking at markers of fibrosis like galectin-3. Some sub-analyses of the RELAX-HF trial, for example, tried to look at that and did not find any relationship with clinical severity or with response to sildenafil, at least in that one study. So I think biomarkers, even though we so much want to have just that number that tells us, yes, you have heart failure, no, you don't have heart failure, or yes, there is a clinical exacerbation, or no, there is not, I don't think that those are going to be diagnostic tests that we can use alone. I think they're going to have to be integrated with our
in prognostic.
I'm sorry?
Prognostic?
And I think prognostically, certainly with BNP, what we do know is that, yes, it may be altered, and certain comorbidities do affect it, but like you mentioned, when it is present, when it is elevated, we know that it has prognostic significance and correlation with poor outcomes.
Thank you. San, are you a biomarker-oriented individual?
I'm sorry, say that again?
If you are a biomarker-oriented individual.
Am I biomarker oriented? I think so. I mean, I think it's important to understand what is the trigger for BNP release. So BNP is released in a direct correlation to left ventricular end diastolic wall stress. So if you think about the typical phenotype of someone who has heart failure and a preserved ejection fraction, they often have left ventricular hypertrophy. So that left ventricular hypertrophy, to a certain extent, normalizes wall stress. It's one of the reasons why when you see patients with HFpEF, they don't have significantly elevated BNP. On the other hand, if you come across someone who has HFpEF and an elevated BNP, then that signifies a heart that's under much higher strain. So either they're no longer able to normalize their wall stress, or you now have significant pulmonary hypertension with right ventricular strain. And the source of the BNP release is from right ventricular strain. Now, this is very important when we look at the TOPCAT study. I'm sure you'll come to it later, but it helps to explain the observations that they encountered in TOPCAT, where if you look at the enrollment criteria for TOPCAT, you either needed to have a heart failure hospitalization or an elevated BNP. If you stratify patients based upon those who were enrolled due to a higher BNP level, their outcomes, particularly in the placebo group, were much, much higher than the placebo group from the group that had heart failure hospitalization only and normal BNPs or minimally elevated BNPs. If you look at just the group that had elevated BNP, the addition of spironolactone actually did have a significant benefit, reducing both heart failure hospitalization and mortality. You know, clearly wasn't powered enough to detect a sole difference in cardiovascular mortality, but nonetheless, there was a very positive signal there. So I think HFpEF with high BNP is a very bad combination.
You agree, though, that it is much more common and reliable on reduced ejection fraction patients?
Absolutely, and there I think we have very good evidence to suggest its role in diagnosis. We have very good evidence to show its role in assessing prognosis, and pretty good evidence, evidence which is emerging about using it as a marker to help guide outpatient therapy. So that's clearly established, I think, in HFrEF, or heart failure reduced EF.
Okay, now I think I'd like to touch into the most important part, and that is what is really going on. Because we are all talking about biomarkers and relaxation, measurements, strain, and so forth, and I'd like to put Parto and Inés here on the situation that I'm going to present first, because I think it's critical, and this is basically the overall feeling at the present time. One cannot be accurate in something that is so complex, but we have two important situations here, and this is critical to understand treatment in a moment. The first are the comorbidities. The comorbidities by themselves, we already talked many times today, can lead to problems, whether it's hypertension, anemia, sleep apnea, COPD, and so forth, which we will discuss one by one in a moment. And the other is what happens in the myocardium as a result of these comorbidities having an impact in the myocardium. Now, first of all, let me finish this because it's important. Now, the comorbidities that can actually have an effect by themselves, detrimental effect, they have an effect in the myocardium, and here is where by biopsy has been identified TGF-beta, TNF, interleukin-6, and CRP. This has been identified in the biopsy. So there is an impact of these risk factors. Some people like to call this inflammation, but basically that's what it is. Of all of those, there is one of them that causes fibrosis, that is TGF-beta. I think this is critical because all these hearts on biopsy has a fibrotic phenomena. Now the question is, what else is happening? Why there is hypertrophy and stiff muscle? And this is because this chemistry that I mentioned produces respiratory oxidative stress, which is something the free radicals are beginning to be quite important in cardiovascular biology. And the result of this is a decrease of NO, nitric oxide. And the decrease in nitric oxide leads to hypertrophy and stiffness of the muscle, and at the same time leads to microvascular disease. So I'd just like to summarize the biopsy specimen. Has fibrosis, the TGF-beta, has microvascular disease, typical in diabetes and hypertension, hyperlipidemia, for example, by lack of NO and vasoconstriction, has hypertrophy and stiffness, is the lack of NO, and then obviously this aspect of the myocardium in itself is also a killer. So we have to completely distinguish the risk factors or comorbidities, what they do by themselves, and the impact that they have in the myocardium, leading to the entity that we are discussing today. Now, having said that, I'd like to ask you, Partho and Inés, how you feel about this scheme of comorbidities on one side and the impact that people like to call inflammation on the other, on fibrosis, microvascular disease, hypertrophy, and stiffness, because now we are going to talk about what the trials have shown, how they affect each of these aspects that I'm discussing. So can you comment on?
Yeah, so I think the clustering of the risk factors does not just lead to changes in the muscle, it's the entire vascular and the ventricular coupling which is affected. So what you're seeing in the ventricle is in the extreme form of the heart failure with preserved ejection fraction is a form of structural change with altered material properties of the myocardium, with alteration in the dynamic processes of the cardiac cycle. But this is not just isolated to the muscle, it's the entire vascular tree which is linked together, which is failing. Although we are trying to identify at the level of ventricle and the atrium. So fairly complex, but as you correctly pointed out, that the phenotype that clusters in is associated with myocyte hypertrophy. Even in a histopathology, we'll see a myocyte hypertrophy, change in the interstitium with more fibrosis, and concentric remodeling where the myocardium encroaches into the ventricular space. And that's why I think the European wanted to exclude the end-diastolic dilatation dimensional, which is increased from the categorization of heart failure with preserved ejection fraction. But you do see the concentric remodeling, and that's associated with the vascular tree, where you see the more dynamic changes related to endothelial dysfunction and pro-inflammatory cytokine and a host of other factors which lead to a sluggish circulation, elevation of filling pressures, relaxation of abnormalities.
Okay, so it's interesting, Inés, that we have on one hand the comorbid stage, that 4 or 5 of different things that are affecting these patients. On the other hand, these comorbid stages that can lead to mortality by themselves also affect the myocardium, the fibrotic LVH, and all what we discussed. How you understand, when you go to the guidelines, is something very striking, and that is when they talk about this entity, they don't talk about the treatment of the comorbid stage, only reduce ejection fraction, not in patients with persistent or a normal or near normal ejection fraction. Is not an odd situation?
Well, so I can only speculate on this actually, but part of it is that perhaps this has been a paradigm shift as of late, an understanding that the reactive oxygen species do affect the myocardium. So we have this effect of fibrosis on one hand, and the effects of microvascular dysfunction and decreased nitric oxide on the other hand. So I think that part of it is the fact that it is a paradigm shift. At the bottom of the guidelines, there was one small sentence actually saying that we should treat the comorbidities.
Yeah, you have to use a microscope to see it. There's a line down there after you go to 100 pages.
But you're right, in fact, that there's not, a large amount of the guidelines that are spending enough time on focusing on the comorbidities that are probably even more important in this condition.
Alan. Were you part of the guidelines?
I can say no, but I'm on, I'm on the imaging aspect, but not on the ACCHA.
Yeah, but what is your comment about this?
I
Because this
think
is a
that-
complete paradoxical situation we are
I
dealing
think
with here.
that they're recognizing, with the negative trials, they're recognizing that you're dying not from the cardiovascular death, you're dying from the non-cardiac. So they're just recognizing that this is important, but they didn't apply very many sentences to the comorbid conditions, and they're probably the key thing that giving a drug you're going to die from non-cardiac death is not going to really help you unless you treat the underlying condition.
There's only been one trial that I'm aware of looking at exercise training in patients with HFpEF, and that actually did show improvements in peak oxygen consumption, several months after being on a training exercise. So it does help, but you can't write a guideline if you don't have any evidence, and so that's one of the reasons why there isn't. They do speak to managing hypertension and treating coronary disease. And there's emerging evidence about adding statins to patients with HFpEF, focusing on the multimorbid condition and the metabolic syndrome that exists frequently in these patients.
Okay, I'd like to go anew into each of the comorbidities, how they can affect directly your health and how can affect your heart with the kind of inflammation we mentioned before, and what are the trials, what they have shown. And if you don't mind, let me start with hypertension, which for me is one of the most prevalent aspects. We don't have any question that hypertension can kill you. Not necessarily you need an inflammation in the heart. I don't think this is the discussion. It is also obvious that hypertension is very prevalent on the disease that we are talking about. Now, the question is interesting that the agents that have been used for hypertension behind the trials was also because they thought they were going to affect the substrate that we are talking about, inflammation. And I'd like to go one by one of these agents and to see what they show. So in fact, it was a double hit to see what happened. Well, I can go one by one. The first one is beta blockers, was not associated with improvement in mortality or rehospitalization in 3 of the trials. One of them is the optimized heart failure registry. Second, calcium channel blockers, which also the so-called lusiotropic effect did not work, although the trials were very small in number. The third one is the PEP-CHF trial of 850 patients over age of 70, and here they use an ACE inhibitor, peridopril, did not work, perindopril. The fourth is the CHARM trial, which candesartan was used in the so-called, in this particular trial, in which it didn't work. There was no difference at all in the control group versus the treated group. And finally, I want to spend perhaps a minute or two into what was the great hope in the last 5 years, which was the use of mineralocorticoid receptor antagonists, because that's where the TGF-beta may be affected by using spironolactone and then to affect the fibrotic phenomena. Well, the key trial that was mentioned was the TopCat trial, in which over 3,000 patients with symptomatic heart failure and ejection fraction more than 45% were randomized into spironolactone 15 to 45 milligrams daily of placebo. The trial found that neither total deaths nor hospitalizations were reduced by treatment with spironolactone. Well, then they then look at different things retrospectively, and they found that perhaps people with high BNP levels could be affected favorably with the use of spironolactone. I think that's the comment you made previously. Now, those who still believe in the aldosterone inhibition, they feel that maybe it should be given at an earlier stage of the disease. And this is the question that is present at this time. Alan, what is your perception of all these drugs that was so much hope because they not only treat hypertension, but at the same time they go into the substrate we have been discussing, some related to the hypertrophy, there is inhibitors, others related to the fibrotic phenomena, spironolactone. What do you come up with it?
Well, it's very disappointing, but I'm not surprised, as I said, who got into the trials. Plus, it's not, as you pointed out, it's not all diastolic heart failure. There's chronotropic incompetence, they have pulmonary hypertension, they have perhaps the vasculature. Not all the drugs work on everything, and depends who got into the trials. I was hoping that the spironolactone was going to work, but I was disappointed, and perhaps the comorbid conditions were quite different. So I think the trials sort of failed. Who got in? Perhaps the type of drug and perhaps the outcome. Measuring mortality, or cardiovascular mortality, or hospitalizations. If you're dying from a non-cardiac cause, maybe not the right endpoint. Perhaps quality of life, other perhaps softer or similar type endpoints. So there's hodgepodge of reasons why they didn't work.
Anu, comment?
I think even to be a little bit more depressing, to add to the list of things that haven't panned out on a smaller scale, we had hopes for sildenafil based on the Gwazi study, looking at improved outcomes with that, but that was proved to not have an effect in the RELAX-HF trial. Phase 2 trial of ranolazine was a negative study as well. And then I think most recently, maybe hopes can be kind of rejuvenated with the ARNIs, or the ARB neprilysin inhibitors, with the positive phase 2 trial, and now the large ongoing trial that's phase 3 to look at a benefit in terms of clinical outcomes. So it remains to be seen. I think, again, Dr. Klein hit on what we've hit on multiple times today, is really who are the patients that should be included in these trials? Can we hone in and really figure out which population in this large grab bag of the clinical syndrome that we call HFpEF can really benefit from some of these therapies?
Okay, thank you very much. I'd like to touch into COPD, and if you allow me, in sleep apnea, because it's so prevalent and it passes on us, in front of us, and we don't pay enough attention. COPD, 1/3 of the patients with preserved ejection fraction and heart failure have actually COPD. And it is interesting, it has been demonstrated the inflammatory component with oxidative stress affecting the myocardium. However, all the studies show that when you treat COPD, the decrease in mortality has nothing to do with the heart, which is affected with the disease we are talking about today, but basically is by treating the COPD with the discontinuation of smoking, etc., etc. And one of the issues is that, what about beta blockers? And actually, if you go to the guidelines and they look at this disease, they mention maybe you can treat COPD with a beta blocker, which is, of the type that is not general effect, but just cardiac effect. I mean, that's the only question I have. I don't know, Sin, if you have any comments, and then I want to pass very quickly into the sleep apnea, which I think is important. What comments you have about COPD?
So if you're talking about heart failure and a reduced ejection fraction, I would absolutely put everyone on a beta blocker, and they would have to prove to me that they have irreversible, intractable bronchospasm before I would stop the beta blocker. In terms of using a beta blocker in HFpEF, I think there's zero evidence to support doing that. There's theoretical evidence based on tau or time relaxation or the correlation of time relaxation for relaxation, but I think that's all theoretical. I think there's very little evidence to support using a beta blocker in that sense. The problem with COPD is defining what COPD is. So having done all of this work on hospital readmissions, when we've actually gone and done bedside spirometry on patients who carry a diagnosis of COPD, we can't demonstrate that they have COPD. So I think for those patients who have sleep apnea, which is being labeled as COPD, then it's appropriate to treat the sleep apnea, at least obstructive sleep apnea. We have some data now that was presented at the European meetings that treating central sleep apnea in heart failure is not beneficial. But in terms of treating obstructive sleep apnea, I think there's still evidence to support doing that, both with HFpEF and with HFrEF.
Well, I think it's a very good summary. I like just to mention that in the literature, patients who have sleep apnea, which is, I like to focus on that, in patients with cardiac failure is 50 to 80% is quoted. Do you believe this, Alan? Is sleep apnea so prevalent? Many of these patients have obesity, of course, and they have obstructive type of sleep apnea, but many have actually central type of sleep apnea, and they are in cardiac failure in one or the other type.
So with HFpEF, I'm always intrigued about the elevated pulmonary pressures. A lot of studies actually from Mayo Clinic have shown pulmonary hypertension as one of the key findings, and they go hand in hand. So perhaps, these people have more sleep apnea, pulmonary arterial hypertension. So I think it could be an issue. And importantly, the sildenafil relaxed heart failure didn't show any benefit. But I think pulmonary hypertension is quite key, and perhaps the sleep apnea may be causing it.
I'd like to comment a little bit on the study that just was mentioned by Son, which is about the recent paper. It was published in the New England Journal last week about the use of CPAP in patients with cardiac failure and sleep apnea. These patients had systolic heart failure, however, as you said. But I think this is very interesting paper in which they really show that the all-cause mortality and cardiovascular mortality was significantly higher in the group who had the sleep apnea and in terms of when CPAP was used compared with the control. There's been a lot of noise about this. The results were not overwhelming. Mortality goes from 29% to 24%, 29% in those that used CPAP versus those who didn't. It's not an extraordinary difference. I still feel, though, that the use of CPAP makes patients to feel much better. And I think my interpretation of all these studies that only look at mortality, we have to open this to question, because we have to the well-being of the patient is also part of the story. I hope you're in agreement with that.
Absolutely. I think it's important also to point out that this was in central sleep apnea, not obstructive sleep apnea. So we don't have any data on obstructive sleep apnea. I also give the investigators a lot of credit for doing this trial because everyone assumed that it would work. There were smaller trials, smaller clinical anecdotes that would suggest that this would be beneficial. The company didn't need to do it. They already had the right to sell their product without an indication. So this was a clear example of the reason why we do what we do in academic medicine, which is to not just rely on theory, but to actually test it. So I think it was a very good trial, and they should be congratulated for doing it.
Final comment is that the other entities we can talk about is anemia, diabetes, and renal dysfunction. It's the same than the others, but most of these patients actually died of the original disease rather than of the problem of the heart. I will tell you, by reviewing all the literature, at least, I like, Alan, what is your opinion? In reviewing all the literature, one gets the impression that has been a lot of focus on the disease that is already advanced, which is cardiac disease with already patient in cardiac failure. And then they try to treat the original comorbidity state, and it's too late. So even by definition, to me, all these trials are too late. You start treating hypertension when hypertension has already caused so much disease, and not only on the heart, but on the kidney and everywhere. So I think to me, when you look at this subject, first we have to define it properly, and I think we went over in great detail. The comorbidities are essential to take into account, but I think this is where the field of prevention should really come, rather than allow these patients to get into the stage that they are selecting themselves very late in the game with heart failure, with hypertension for 20 years. So this is at least the way I see the subject. I'd like you, Alan, to make a final comment before we open this for discussion, because I know you have to catch a plane.
The importance of picking up early disease, subclinical disease, is quite crucial. It sort of reminds me of the initial enthusiasm giving statins for aortic stenosis, but if you give it too late, it's not going to work. Perhaps strain, speckle tracking, or myocardial deformation can pick up earlier changes in the myocardium, let's say in diabetes, renal failure, and perhaps you would give the spironolactone or the other types of drugs earlier, the ACE inhibitor, A or B, and perhaps you can make a difference. Perhaps it's too late in the disease. But spectral tracking has that potential, and I'm sure you see a lot of papers in JACC about early detection of disease.
Dr. Sengupta, you agree. It seems to me that this is probably the technique of the decade if you want to get into the subject in a very early stage. Is not correct?
That's correct. So I think my comment would be that, as I said, it's very heterogeneous. We need what is like a phenomapping approach to really develop individual identification of disease patterns and then only individualize the therapy, because just blanket therapy of a beta blocker for everybody or ACE inhibitor is not going to work. But on the other hand, like distinct cases where if there is tachycardia, you have to improve the diastolic filling by cutting down the heart rate. So there are some subset of patients who may benefit from them. So we have to identify the phenomapping, use early detection using tissue tracking, speckle tracking, see the risk factor and be able to predict which way the patients are going and how, and then try to arrest the development of heart failure rather than trying to treat the heart failure.
Except that when we see atherosclerotic disease and you show to somebody who is asymptomatic, they don't change lifestyle. So we have a huge behavior issue when we go into early stages of disease, regardless what the biology is. But the interventionalists always have their last word. And this is actually what happened. So Dr. Vivek Reddy came to see me on a hurry this afternoon. And is he here? Yeah. And he said, I have the answer to treat this disease. And I said, well, obviously, if you take the heart out, he says, no. He shows me a paper that says transcatheter treatment of heart failure with preserved or mildly reduced ejection fraction using a novel interatrial implant to lower left atrial pressure. Can you make a comment?
Yeah, sure. So this is not a treatment for MS. The idea is, in a situation where you have patients that need, some people really in extreme heart failure, this is a palliative approach. The idea is, the idea is based on the observation that patients who have an ASD.
Make it short. Okay. Short.
Well, basically, the idea is to create an ASD, a mechanical ASD. So basically, there's a little stent-like device placed in the atrial septum that basically allows a left to right shot. And the idea is, of course, when patients with HFpEF, when they exercise, that's when the left atrial pressure really goes up when they have a good technology. So the idea is to allow a relief valve so that the left atrial pressure decreases. So this was studied in a first-in-man study, what you're referring to, just to show that it can be done, that left atrial pressure decreases. It decreased from a mean of 18 to 13 or something without a significant increase in right atrial pressures out to 1 year. Now, this is all non-randomized data. There's a larger European CE mark study, but most importantly, we're going to be starting a randomized trial here in the U.S. It's an IDE with our heart failure colleagues in HFpEF patients. So again, this is not going to be a treatment for HFpEF, but it's for patients who are very symptomatic, where all you can do is give, really Lasix at this point.
This is different. This is different than in pulmonary hypertension, in which the creation of atrial septal defect led to a right to left shunt.
Right. Exactly.
That was the problem. This at least is a left to right.
This is a left to right shot. No, absolutely.
Yeah. Questions or comments? Yes, Dr. Friedman.
Yeah, in practice, I don't know about E to A ratios too much because I don't do them that much, but in practice, almost everybody over the age of 65 has diastolic abnormalities, and you kind of walk away and you say, well, the heart got old, and yet they don't have heart failure. And I don't know how central that is to making the diagnosis, but if you look at people with normal BNPs and then you refer to data that, in my opinion, just shows an old heart as opposed to a heart that's failing, you begin to wonder about the logic of that and even how you define heart failure. So I guess also I would say that I have patients with high BNP and no symptoms at all. And it seems that some of the patients who I would say have old hearts, they just have kidneys that can't deal with it. You know, they just can't dump the salt that you give them, and then all of a sudden an old heart becomes a failing heart. So I just wonder that maybe we shouldn't the BNP, the negative BNP, because of there may be a lot of false positives if you use the echo Doppler, and that the negative BNP actually may be a valid technique to rule out heart failure.
Comment, Alan?
So that's a very good point. So the question is, in the elderly, how do you make of diastolic filling abnormalities, and how does that relate to the BNP or pro-BNP? Well, as you age, all of us will end up with most likely grade 1 diastolic filling abnormality. What does that mean? Well, that's part of aging. It may be normal for that age. It'll be very rare in a stage 1 or grade 1 to have an elevated BNP, unless you have some renal dysfunction, as you point out, or some other comorbid conditions. Having said that, having a grade 1 diastolic function abnormality is predictive. There's a certain percent, a low percent in developing heart failure in the future. But in the elderly, this is a common finding, and should you report abnormal or is it normal for age? That's another aspect. Definitely, grade 2 or grade 3 is much more predictive, but the grade 1 is probably part of the aging process. Unless you're a master's athlete, you may not get that.
You know, think too about HFrEF, or systolic heart failure. You can have left ventricular systolic dysfunction and be asymptomatic. You know, we used to call that asymptomatic left ventricular dysfunction, or maybe now say it's stage B heart failure. But just because you have an abnormality on echo doesn't mean that you have the clinical syndrome of heart failure. Heart failure still remains a clinical diagnosis, not an echo diagnosis.
If I can make one other point, in that particular patient, you have an elderly patient that has dyspnea. You don't know if it's cardiac or non-cardiac, and they have grade 1 diastolic dysfunction. You do a diastology stress test, or if they can do a treadmill, and then you can see if their pressures go up, E over E prime, a very simple thing to do. If it's negative, then perhaps it's non-cardiac.
Just ask, I mean, you all mentioned how we approach patients, but when you read these studies, at least they're quoted, I've not read them, but reading this, it's not clear the kind of logic that you're using now, referring to individual patients, is somehow paid attention to when we do these large studies and come up with these things about, low BNP not matter. How are we supposed to know anything?
You have a disease where you have a hard time defining the population. You have a disease where you can't define the pathophysiology. So it's not surprising that we have a number of trials where we have a negative result. So there are a couple things that we can do. So one of them is to go back and do a meta-analysis. When you do a meta-analysis testing RAS inhibition, you actually see that there's a signal there. We saw from Charm Preserve that the addition of an angiotensin receptor blocker can reduce hospitalizations. We have the secondary endpoint in TopCat showing that spironolactone can reduce hospitalization. And in at least half of the patients who were recruited in TopCat, if you exclude the ones who were at lower risk, if you look at a higher risk population, you can show that spironolactone actually had a clinical benefit. The other thing we can do besides meta-analyses is you can look at observational databases. So Europe has a great observational database. Scandinavia and Sweden, they have a great observational database. So when they looked at 36,000 patients with HFpEF, they showed that there was a significant advantage to being on some type of RAS blocker, either an ACE inhibitor or an angiotensin receptor blocker. And when they did propensity matching, so match age to age and comorbidity to comorbidity, they still showed that there was a signal there that there was about a 10% relative risk reduction in hospitalization and cardiovascular mortality associated with RAS inhibition. So I still haven't given up on that hypothesis that RAS inhibition works in patients with HFpEF. If you consider the...
Can I ask you, Dr. Alan Klein, you stay here. He has to catch a plane, and I really know what is catching a plane getting late.
Okay. Well, thank you very
much for Yeah, you can continue.
So I think I haven't, I'm still, very positive on the RAS inhibition hypothesis. If you consider the fact that 80% of patients with HFpEF are going to have high blood pressure, you're going to need to put them on an agent. I wouldn't put them on a beta blocker. I would put them on a RAS blocker. I'd probably start with an angiotensin receptor blocker. And then if they can tolerate it from a renal perspective and a hyperkalemia perspective, then I'd put them on an aldo blocker. So the addition of an aldo blocker should also help to control some of the symptoms of congestion. So that combination, I think, does work. I think the most important thing to do is to get them out and exercise, to reduce their caloric intake, to make sure that they exercise, to control their diabetes, to control their blood pressure. Whether or not the horse is out of the barn, I don't know. I think in many cases it is. But given the fact that we now have emerging evidence that there is this link to systemic inflammation and metabolic syndrome, the things that work there with modifying your diet, exercising, taking a statin should work in HFpEF as well.
Okay, I'd like a final comment from each of you. What would be the message, Ines, after this discussion today, or something you have learned, or something you would like to say? Just a single message, no more than 30 seconds each.
Heart failure with preserved ejection fraction is a complex entity where the patients have a lot of comorbidities that need to be addressed.
Good. 15 seconds.
Heart failure is a complex syndrome of multiple heterogeneous diseases existing together, which requires a phenomapping approach and individualized therapy.
Thank you. Son?
We have a gathering storm of heart failure preserved ejection fraction cases coming due to the aging of our population, the obesity in our population, and the rampant prevalence of diabetes. If we don't control the risk factors, we're going to see more and more HFpEF. And since we don't have great drugs to treat it, we're going to see a lot of patients who are symptomatic.
And to get them early.
Get them early.
Anu?
I think a lot has been already touched upon, but I think I wanted to emphasize from my standpoint that really keeping in mind that heart failure with preserved ejection fraction is a clinical syndrome, as Sean mentioned. It's not just one thing that we hang our hat on. It's not just one echo parameter, one biomarker, or one comorbidity. It's a constellation of all of these things that end up manifesting as the clinical syndrome we know as heart failure with preserved ejection fraction. And that's why it takes looking at every aspect of it to be treated.
Okay, thank you very much to all of you. Thank you.